Welcome to the deep dive. We're taking that dense, high-stakes material.
The stuff you absolutely have to know.
Exactly, and we're making it clear, actionable. Today we are diving into one of the most critical concepts in acute care, the language of shock.
And it really is a language. I mean, shock is the ultimate failure state in the body.
Right.
When you really boil it down, the definition is just global tissue hypoperfusion.
So, not enough oxygen getting where it needs to go.
Precisely. It's the failure to adequately deliver oxygen, we call that DO, to the tissues, and that forces cells to switch to these emergency, really inefficient fuel sources.
And that's what leads to organ dysfunction.
That's the end result.
So our mission today is to cut through all that confusion. We want to classify shock not just by name, but by its underlying mechanism.
Yes.
We want to give you those precise arrow patterns, the clinical buzzwords, so you can differentiate the four critical types, well, instantly.
To do that, we have to understand where the system failed. The body's circulatory system is. It's like complex plumbing.
Okay, I like that.
You need volume in the pipes, you need a working pump, and you need the pipes themselves to be open and have the right amount of tone.
That plumbing analogy gives us the perfect roadmap then. Let's use it right now to classify the four big failure modes.
All right, first, if you have low volume, that's the empty tank.
Which we classify as hypovolemic shock.
Then, what if the volume is fine, but the heart muscle itself is failing? That's your broken pump.
Cardiogenic shock.
Exactly. Third, the pump works, the tank is full, but something external is blocking the flow, either coming in or going out.
The obstructed pipes.
That's obstructive shock.
And then there's the last one, which always felt the most insidious to me. The total fluid volume is fine, but the pipes themselves get super wide or leaky and the pressure just collapses.
The leaky or wide pipes, that's distributive shock.
And that's where we find sepsis.
Right. That's the big one in that category, that simple structure tank, pump, pipes. That should really anchor everything we talk about today.
Okay, great. So before we dive into the four types specifically, the notes really emphasize that shock is a progression. It's not an on-off switch. It's a race against time.
Absolutely. It moves through stages.
Ah.
And the body fights back hard in the beginning. In that first stage, compensated or early shock, the body detects the pressure drop and it slams on the gas.
The sympathetic nervous system.
The SNS and the RAS pathway. The whole goal is to preserve blood flow to the brain and the heart at all costs.
And the sources are so clear on this. If you're trying to spot shock early, that SNS response gives you the first high-yield clinical clues. I was actually surprised that the most universal initial response is always tachycardia.
That's such a key insight. Baroreceptors in your arteries sense the pressure drop, and the body's immediate fix is to just crank up the heart rate.
Because cardiac output equals heart rate times stroke volume.
Exactly. And since stroke volume is often the thing that's failing, the only lever the body can pull immediately is that heart rate. You'll also see anxiety and that cool, clammy skin as blood gets shunted away from the periphery.
So tachycardia is first, but it's not the most specific sign. When does the body really signal that, the fight is being lost?
That happens when we slide into decompensated shock. And the signal for that is hypotension.
The blood pressure drop.
Yes. When the systolic pressure falls below 90, or the NAP goes below 65, that means all those compensatory mechanisms are being overwhelmed. We are truly in a crisis now.
And at that point, it doesn't matter what started it. Pump, pipes, volume. The cellular starvation has one universal consequence.
The switch to anaerobic metabolism. No oxygen means the cells have to burn fuel inefficiently, and the waste product is lactic acid.
So lactic acidosis.
A massive increase in it. High lactate, usually over 2, is the definitive lab finding. It confirms global tissue hypoperfusion is happening right now.
And if that's not stopped,
you reach the final stage, irreversible shock. Cell death is so widespread that even if you fix the pressure, it's too late. Multi-organ failure is inevitable.
Okay, so with that timeline set, let's pivot to diagnosis at the bedside. We can start with the three types that are often grouped together because they share one very visible feature: the cold shock presentation.
Right. Hypovolemic, cardiogenic, and obstructive shock. They all share high SVR, systemic vascular resistance.
The tightness of the pipes.
Exactly. The body sees low cardiac output, and its only response is to clamp down hard on the peripheral circulation vasoconstriction to shunt all the blood centrally. That's why the skin feels cold and clammy.
But internally, their hemodynamic profiles, those arrow questions of CO, SVR, and preload, they're wildly different. So to decode this, we probably need to quickly define preload. By focusing on the hemodynamics and, more importantly, the bedside clinical clues, you should be able to instantly categorize the problem and know exactly what to do.
And before we even get into telling them apart, we have to stress the non-negotiable first step, right?
Mhm.
The ABCs. Airway, breathing,
Right.
circulation. You have to secure the airway, make sure they're getting oxygen, and get large bore IVs in immediately. That's for every single type.
Every single time, exactly. But here's the critical insight, and this comes straight from the latest critical care guidelines. This is what separates just, treating hypotension from actually fixing the problem, the tissue hypoxia. The best early indicator that your tissues are starving is often not the blood pressure. It's the serum lactate.
That's so crucial.
Yeah.
Because the blood pressure can look fine, or at
Yeah.
least okay in the beginning, can it? Deceptively normal.
Absolutely. The body is an amazing compensator. It can squeeze those blood vessels like crazy to maintain a mean arterial pressure, a MAP. We want to keep that MAP above 65 millimole G to perfuse the brain and kidneys. But even while the MAP looks okay, huge parts of the body might have already switched to anaerobic metabolism, and that is what produces the lactates. If you see that lactate spiking, you are in a silent race against time. The real measure of success, the most reliable one, isn't just a normal blood pressure. It's seeing that lactate clearance. It's watching that number trend down.
Okay, so let's unpack this. We can start with the cold shocks. They're grouped together because they share one key physiological response, which is a high systemic vascular resistance, or SVR, so the body knows something is wrong with the circulation, and it compensates by just clamping down hard on all the peripheral blood vessels. And that's why the skin is so cool and clammy.
That's it. Hypovolemic shock. We could just call it the empty tank.
Mm.
This is just pure volume loss. So massive bleeding from trauma, extreme dehydration, or those huge fluid shifts you see with severe burns. The core problem is a massive drop in preload. There's just not enough blood coming back to the heart.
And when you look at the numbers, at the pressures inside the system, this has to be the lowest pressure state possible.
It is. Hemodynamically, you're going to see a drastically low central venous pressure, the CVP. That's the pressure coming back to the right side of the heart. And you'll also see an extremely low pulmonary capillary wedge pressure, or PCWP, which sort of estimates the pressure on the left side. Cardiac output is low, and like we said, the SVR is cranked way up high. Clinically, what you see is flat neck veins, so low JVP, dry mucous membranes, and a very, very narrow pulse pressure. That's the difference between the systolic and diastolic numbers. And it's narrow because that vasoconstriction is trying to keep the diastolic pressure up.
So the immediate action is obvious. You have to replace the volume.
Mm-hmm.
Rapid isotonic crystalloids like lactated ringers is step one. But if we know the cause is a massive hemorrhage, like a trauma or a GI bleed, fluids alone are not enough.
Not even close. You just can't replace blood with saline. If it's bleeding, you need rapid blood transfusion now. And you have to control the source of the bleeding. Our sources also really emphasize a key drug here, early administration of tranexamic acid, or TXA. If you give it within 3 hours of the injury, it's been shown to reduce mortality in patients with significant bleeding. That's a huge detail.
Okay, now let's flip to the other major cold shock, cardiogenic shock, so the broken pump. Here, the pump itself, usually the left ventricle, is failing. Often after a big heart attack, the body still cranks up the SVR, so you still get that cold, clammy skin. But inside, the pressure situation is the complete opposite of hypovolemia.
This is where we use those pressures to tell them apart. The heart can't push blood forward, so blood backs up into the system. This gives you a hemodynamic profile of high PCWP and a high JVD. Cardiac output is low and SVR is high.
So this is the key differentiation point. This is what you have to get right at the bedside. If both patients are cold and clammy, what stops me from accidentally giving a huge fluid bolus to the patient having a heart attack?
It's the signs of that backup. You have to look for the external signs of volume overload. You'll see visibly elevated JVD, those distended neck veins. And when you listen to the chest, you hear pulmonary crackles. That's the sound of fluid in the lungs, pulmonary edema. You have to avoid fluids. If you give fluids here, you will make the backup worse. You will drown the patient.
So management needs incredible finesse here. We're using norepinephrine as the first-line pressor to keep that MAP above 65. But we had to be so careful not to overload that failing heart.
And we use inotropes, drugs like dobutamine, which increase the force of the heart's contraction. It sort of gives the broken pump a kick, but that's only if the blood pressure is stable enough to tolerate it. But really, fundamentally, if the shock is from a heart attack, the definitive treatment isn't a drug at all. It's a procedure. Early reperfusion with a PCI, getting that blocked artery open, is what truly improves survival.
Okay, this is where it gets really, really interesting. So we've covered the cold shocks where the body is, compensating too hard. Now let's look at the problem where the compensation just completely fails. That shifts us to distributive shock, which we call warm shock in its early stages. The problem here isn't the pump and it isn't the volume, it's the pipes. The blood vessels have lost all their tone and are just massively widened.
Right. This failure of tone, this massive vasodilation causes an extremely low SVR. The total amount of blood in the body hasn't changed, but because the container it's in is now giant, the patient is relatively hypovolemic.
And the most common and probably highest stakes type here is septic shock. What is it that drives this incredible loss of vessel tone?
It's a systemic inflammatory cascade. It's triggered by an infection, endotoxins from bacteria, and that leads to this massive release of vasodilators, primarily a molecule called nitric oxide, or NO. Because the vessels are so wide, the heart initially tries to compensate like crazy.
That sounds like a hyperdynamic state. So what does that look like on the monitor?
That's a great way to put it. Early septic shock. It typically presents with a high cardiac output, a high CO, and that critical signature, a very low SVR. The PCWP and CVP are usually low because all the blood is just pooling out in the periphery in those dilated vessels. And the key clinical clue is really counterintuitive. Despite being profoundly hypotensive, the patient has warm, flushed skin and bounding peripheral pulses.
So immediate action here is a genuine race against the clock. We start with blood cultures, but the sources are so emphatic about this. You follow that immediately with early broad-spectrum antibiotics. Every single hour of delay increases mortality.
Right. And at the same time, we're starting prompt crystalloid resuscitation, that famous 30 millicalogy fluid bolus. But if the hypotension continues, if that MAP is still under 65, we have to start artificially squeezing those vessels shut. And norepinephrine is the first choice vasopressor to increase that SVR. And if the shock is refractory, persistent despite high doses of pressors, you have to consider adding hydrocortisone. There might be a relative adrenal insufficiency going on.
Okay, staying in the distributive family, let's contrast that infectious cascade with anaphylactic shock, the allergic blowout. The mechanism is different, but the result, that massive vasodilation, is the same.
It's a sudden IgE-mediated catastrophe. Mast cells just dump huge amounts of mediators, especially histamine. So you get that systemic vasodilation and capillary leak, just like in sepsis. But, and this is the scary part, you also get the addition of bronchospasm. The airway starts to close.
So the clinical picture has to be totally different from sepsis then.
Oh, completely. It's a rapid onset after an allergen exposure, and it's defined by the classic signs of allergy. So urticaria, that's hives, angioedema, which is swelling, severe respiratory distress like wheezing or stridor. And the immediate life-saving first-line therapy before fluids, before anything else, is IM or IV epinephrine. Epinephrine is the perfect drug here. It reverses both the airway obstruction and the vasodilation at the same time.
And finally, there's one more tucked into this distributive category, the special case of neurogenic shock. This is from a high spinal cord injury, where the patient just loses all sympathetic tone, leaving the vessels wide open.
And this has a critical differentiator. They are hypotensive and warm with a low SVR, but they present with a finding that is highly unusual for any kind of shock: bradycardia, a slow heart rate. That loss of sympathetic input leaves the parasympathetic or vagal tone completely unopposed, and it just drops the heart rate. Management here needs fluids plus strong vasopressors. Sometimes phenylephrine is a good choice for its pure vasoconstriction, and then atropine for that dangerously slow heart rate.
Okay, now we have to cover the mechanical type of shock, obstructive shock. This one is unique because the heart could be perfectly healthy, the vessels might have tone. But there's the physical barrier blocking the blood flow, either into the heart or out of it.
Exactly. This is a mechanical crisis, and it requires a mechanical fix. The common mechanism is either extrinsic compression, so something squeezing the heart, or a physical blockage inside. And it immediately stops the heart from filling or emptying properly, which just tanks the cardiac output. The key clues are a sudden collapse with JVD, those distended neck veins. But interestingly, the lungs are often clear. That's because the blockage is upstream, so blood never even makes it to the left heart to back up into the lungs.
And our sources give us 3 classic examples, and these demand that you act within minutes, sometimes seconds.
First one is a massive pulmonary embolism, or PE. A huge clot blocks the outflow from the right ventricle. The RV acutely fails, and almost no blood gets over to the left side, so your preload just disappears. If this patient is unstable, you do not have time to wait for a CT scan. The treatment is immediate reperfusion. That's usually with thrombolysis, clot-busting drugs, or maybe an embolectomy.
Okay, second one, cardiac tamponade. This is where fluid fills the sac around the heart, the pericardium, and just squeezes it from the outside. The classic presentation is Beck's triad, hypotension, JVD, and muffled heart sounds.
Right, and the specific clinical pearl here is something called pulsus paradoxus. That's a drop of more than 10 millimilli Hg in the systolic blood pressure when the patient breathes in. That pressure swing is diagnostic, and the treatment is an urgent pericardiocentesis. You have to get a needle in there and drain that fluid to relieve the pressure.
And the most urgent procedural emergency of all, tension pneumothorax.
Yes. Air builds up in the chest and it pushes the entire mediastinum, all the structures in the middle of the chest, over to the other side. It literally pinches off the major veins that are trying to return blood to the heart. Clinical signs are tracheal deviation away from the affected side and absent breath sounds on that side. You do not wait for an x-ray. If you wait, you have lost the patient. The action is immediate needle decompression followed by a chest tube. The key takeaway for all obstructive shock is that the treatment is procedural and it has to happen right now. And as we've been stressing, successful resuscitation, it's not measured by just static numbers. It's not just when the blood pressure looks good. It's complete when the signs of tissue starvation are gone. So that means your monitoring goals have to center on aggressive lactate clearance and making sure there's adequate urine output. If the blood pressure looks great, but that lactate is still high, you're dealing with persistent tissue hypoxia. We call that a cult shock.
And we also need to point out that some of the old static measures we use, like central venous pressure or CVP, they're actually pretty poor predictors of whether giving more fluid will even help. They can be misleading.
That's a huge piece of modern critical care. Instead of relying on static filling pressures, we rely much more on dynamic parameters. Things like watching the patient's hemodynamic response to a passive leg raise. That can help gauge fluid responsiveness. It tells you in real time if the patient's heart can even handle more volume.
And when it comes to prognosis, you mentioned there are markers for concern. What are the signs that tell us the patient is crashing, despite everything we're doing?
The big signs of a poor prognosis are a persistently high lactate, usually something over 4 millimol, and then what you can see with your own eyes. That's evidence of poor peripheral perfusion, so specifically cool, mottled skin with a prolonged capillary refill. The failure to reverse shock often leads to that terrifying endpoint of multi-organ failure, or MODS. That includes acute kidney injury, ARDS, and widespread clotting problems like DIC.
So we've really covered the whole map. We have the cold shocks, that's hypovolemic and cardiogenic. They're defined by high SVR, and you tell them apart by looking at filling pressures. Then we have the warm shocks, the distributive types, defined by low SVR, and you differentiate those by the cause infection, allergy, or a spinal injury. And finally, obstructive shock, the mechanical crisis that needs a procedure now.
That's the framework. And prompt recognition and intervention based on those key differences. It's just non-negotiable. So if delayed antibiotics in sepsis increases mortality and a delayed decompression in obstructive shock is fatal, it raises this, I think, provocative question for you to explore. And it's really centered on the urgent nature of all of this. In a world where we have access to incredible imaging CT scanners, advanced MRIs, how do we best balance that need for a comprehensive, confirmed diagnosis with the crucial urgency of immediate life-saving action based purely on those essential bedside clinical signs we just talked about?
Right. Where is that line? When does a bedside diagnosis have to trump the need for a perfect picture from a CT scanner?
Hypovolemic shock.
This is just pure volume loss. Hemorrhage, burns, massive GI losses. Since the tank is empty, the hemodynamic signature is crystal clear. Cardiac output is down, PCWP is down, CVP is down.
All the flow and volume markers are low.
All low. And to compensate for that lack of volume, the SVR cranked way up.
So clinically, that low CVP, that low preload, it shows up as flat neck veins, and that is a crucial contrast to the other types of cold shock.
It's a huge tell. And another great clinical insight here is the orthostatic hypotension test.
The tilt test.
Right. If the patient sits up, their blood pressure plummets, a drop of 20 or more in systolic.
Yeah.
But because their SNS is intact, they respond with this fierce burst of compensatory tachycardia.
That combination just screams true volume loss.
It really does.
Okay, now for the next cold shock type. Cardiogenic, a broken pump. This usually follows a big event, like a heart attack.
Yeah, an MI, a severe arrhythmia. Here, the heart muscle itself just fails. The tank might be full, but the pump isn't moving the fluid forward.
So CO is way, way down.
Massively down. SVR is still high, the body is still clamped down. But the defining feature, the thing you have to look for, is the preload. PCWP is high, CVP is high.
That backup, that's the whole story right there.
It is. If the left ventricle is failing, blood backs up into the lungs. So the clinical signs are pulmonary edema. You hear crackles or rails. And then systemic venous congestion, which shows up as JVD, jugular venous distension, in the neck.
And this is where that life or death treatment dilemma comes in.
Absolutely.
If you see that profile, giving fluids the exact right treatment for hypovolemic shock will actively harm the patient. You're just pouring more water into a house that's already flooded.
It makes the pulmonary edema so much worse. Knowing the difference between low preload and high preload is everything.
Okay, let's hit the third cold shock type, obstructive shock, the blocked pipes.
Here, the heart muscle's fine, it's intrinsically normal, but something external is blocking the flow. It's a mechanical problem.
Think of the big three.
Massive pulmonary embolism, cardiac tamponade, or attention pneumothorax. In every case, CO is down, SVR is up.
But the preload situation can be kind of variable, which I find confusing. How do we spot the big, scary causes?
You look for the classic presentations. If you suspect cardiac tamponade fluid squeezing the heart, you're hunting for Beck's triad.
Hypotension, JVD, and muffled heart sounds.
And you couple that with pulsus paradoxus, where the blood pressure drops significantly just with a normal breath in.
And what if we suspect a massive PE? That's an acute right-sided failure, right? The blockage is in the pulmonary arteries.
It is, and the buzzword combination here is absolutely critical for you to know.
Sudden shortness of breath.
With JVD and clear lungs. That is the clinical high point. It's how you tell it apart from cardiogenic shock. The lungs are clear because the traffic jam is before the left heart. The blood never even gets there to back up into the lungs.
That combination points you straight to a mechanical block.
It's a huge clue.
Okay, so now we pivot completely. We go to the other side of the spectrum. Warm shock or distributive shock.
Right, we're going from vasoconstriction, that clamping down, to massive vasodilation.
So in this whole group, the core problem is a profound drop in SVR. The pipes just lose all their tone, they widen out.
And because of that massive new capacity, the effective circulating volume just collapses and the pressure plummets with it.
The most common example here, the one we see all the time, is septic shock.
Yeah, driven by infection and that cytokine storm, those inflammatory mediators, especially nitric oxide, are just incredibly powerful vasodilators. SVR tanks and PCWP is low.
The thing that always surprised me was the initial hemodynamic profile of early septic shock, because the body is trying so hard to overcome that ridiculously low SVR.
It goes into overdrive.
The heart often compensates by pushing harder, and you actually get a cardiac output that's elevated at first.
It is the only type of shock that starts out hyperdynamic, and that high CO, combined with the low SVR, leads to that classic warm shock presentation.
Warm, flush skin, bounding pulses, a wide pulse pressure.
And often a fever because of the underlying infection.
So the body is pumping out a ton of blood, but the pressure is still low because the pipes are just too wide. The official definition is key here.
It is. Established septic shock is persistent hypotension that requires vasopressors even after you've given them adequate fluids. And you combine that with the lactate being over 2.
Okay. 2 other key types fall under this distributive umbrella. First, neurogenic shock.
This one is from a catastrophic loss of sympathetic tone, usually a high spinal cord injury, above T6.
So let's connect that back to the tachycardia rule we set up earlier. If the sympathetic nerves are out,
Then the body loses its ability to launch that compensatory tachycardia. And this gives us the pathognomonic clue, the thing you have to look for. It's hypotension with bradycardia.
a low heart rate.
And warm, dry skin. Neurogenic is the only major shock type where the heart rate doesn't go up. It's the ultimate failure of compensation.
And finally, a really rapid, often fatal one, anaphylactic shock.
This is that big IgE-mediated histamine release. Histamine causes just, well, profound vasodilation and leaky capillaries.
And it happens fast.
So fast. Acute hypotension, but you diagnose it with the specific allergic symptoms that go with it. Urticaria, that's hives, angioedema, the swelling, and then the respiratory signs, stridor, and wheezing.
Okay, that structured overview, empty tank, broken pump, blocked pipes, leaky pipes, that gives us the mechanisms. Let's wrap up by synthesizing the essential diagnostic toolkit.
We have to start with the universal sign of failure, lactate. Elevated lactate, again, over 2, is the best global indicator that oxygen isn't getting delivered. It's the one lab you track in everyone, no matter the cause.
And the notes point out that when blood flow is compromised, the kidneys are often the first to feel it.
Exactly. You'll often see an increased BUN to creatinine ratio, usually over 20-1. That pattern suggests a pre-renal acute kidney injury.
The kidneys just aren't getting enough perfusion.
Right. It's common in any low-flow state, like hypovolemic or early shock. And for quick type-specific confirmation, you're looking for things like
High troponin levels in cardiogenic shock.
Indicating cardiac muscle injury, yes. Or elevated procalcitonin or white blood cell counts that suggest infection and septic shock.
But the key really is relying less on one lab and more on the big picture. And that's where the cold versus warm distinction is such a powerful memory aid.
It really is. Cold shock, hypovolemic, cardiogenic, obstructive, they all share high SVR, generalized vasoconstriction. That's your pale, cool, clammy skin.
And warm shock septic, anaphylactic, neurogenic, they all share low SVR from vasodilation, giving you that warm, flushed skin.
And don't forget the clinical clues for venous congestion, for that right-sided backup. It's a common feature of both cardiogenic and obstructive shock. We can use the mnemonic B to V,
Okay, let's run through it. B is for
big JVD,
A for ascites, C,
C for clear lungs. And that's our crucial differentiator in something like a massive PE.
right, K for small sign, U for upper abdominal discomfort from a congested liver.
And P for peripheral edema. If you see signs of venous congestion like JVD or edema, you know immediately you're dealing with a pressure or a pump problem.
Cardiogenic or obstructive.
And you know for sure you are not dealing with an empty tank. The physical exam is still one of the fastest tools you have.
So we've taken this complex topic of shock, we've broken it down by mechanism, we've differentiated the clinical signs, and given you the key hemodynamics to anchor that knowledge.
And as we close out this deep dive, let's circle all the way back to the severity of this. We talked about that transition to irreversible shock, driven by lactic acidosis.
Vicious cycle.
It's a vicious, self-sustaining cycle. When tissue hypoxia is prolonged, that accumulating acid drives more cell damage, which further depresses the heart's ability to contract, which makes the shock state worse.
It's the ultimate ticking clock.
Exactly. So since the shock state is defined by inadequate oxygen delivery, and the acid that results from that guarantees further failure, what does that tell us about the absolute necessity of timing your intervention? How early do you have to restore that oxygen delivery with fluids, with pressors, by fixing a blockage before that cellular damage just crosses a threshold of irreversibility?
A point of no return.
The moment that initial drop in cardiac output happens, the clock starts. And the depth of that cellular debt is what determines whether the stability you achieve later on is truly survival or if it's just a temporary reprieve. That sense of urgency, that's the most important lesson the sources provide.